Any pain?
Just starting.
Just starting. Can you turn your leg in for me? Yeah. Any pain? Turn rotation. How's that? Any discomfort? So here we're working on the psoas. The psoas is a hip flexor, and the space between the ball and the socket here.
It's much easier.
Much easier to walk?
Much easier, yes.
There we go. What's up, everybody? Dr. Ranen here. Today I'm with Mr. Ashcroft. Mr. Ashcroft came in about 3 weeks ago with right-sided hip pain, pain at the front of the hip, loss of range of motion. He was having night pain and difficulty in walking. These are classic symptoms of hip osteoarthritis. We sent him off for an x-ray and we found some mild degenerative changes. Today is his fourth session with me. After his last session, we've seen quite a good improvement. I wanted to use this as an opportunity to show you guys that I don't only treat young spring chickens, I treat patients from all different walks of life. And if you want to talk about an athlete, we have a quintessential athlete here. Mr. Ashcroft, 76 years old. He is surf skiing, yes? Yeah, surf skiing, mountaineering, sailing. He's a bit of an adrenaline junkie. He likes to sail, race sailboats as well. So, yeah, we're going to assess him and we're going to get into some treatment. Please remember to subscribe. All right. Let's get you on your back, please, sir. First thing we're going to do is we're going to start off with our orthopedic assessment to diagnose hip osteoarthritis. So can you bend your knee for me towards yourself as far as you can go? Any pain?
Just starting.
Just starting. All right, is that the furthest you can go in? Yeah.
That's the furthest, without lifting my other knee.
All right, can you turn your leg in for me? Yeah. Any pain?
No, that's fine.
And if you go the other way? Any pain?
Just, I can't turn it any further.
All right, relax for me. Let me move your leg. So that's what we call active range of motion. That is when a patient uses the muscle and the joint. What I'm doing now is called passive range of motion. This is just to test the joint. I'm doing the job of the muscle. Any pain there?
No, that's fine.
That's great. So this is a good improvement because before we were probably getting up to about here and then Mr. Ashcroft was having pain. Now we can go a little further. All right. So here we have hip internal rotation. Any pain?
No, that's fine.
Not
about as far as it'll go, though.
Yeah. Here.
That's okay.
That's also a great improvement. At our last session, which was on Monday, he was having quite a bit of discomfort in hip internal rotation. Here we have external rotation. How's that?
That's good.
Great. So this is called a Faber test for hip osteoarthritis. Let's get you to drop this knee down. Any pain?
It's just starting.
Just starting. All right. And we're going to end with a quadrant scour test. All right, so let's get this hip up for me. If I push down, any pain?
No, it's all right.
And if I come into this position?
No, it's okay.
It's okay.
Mm-hmm.
Any discomfort?
No, it's fine.
Nothing at all. Great. So this is a massive improvement. All these tests were quite sensitive at our last session. Let's do some muscle testing now. Can I ask you to raise your leg, please, sir? All right. Let me just hold on here. Can you push up for me, please? Okay, that's pretty good. Turn your foot out. Push across for me.
Which way?
This way. That's good. Relax. Push inward. Great. Relax. Okay, you're going to keep your knee in this position for me. Please push in. Great. Relax. Can I get you on your side, please? Okay. So, a big stabilizer of the hip are the gluteal muscles. So we want to test them to see how they're doing. Mr. Ashcroft's been doing rehab to activate these muscles. How's the rehab going, sir?
No, it's going great.
Great.
Yeah.
Hold for me, please. All right. Let's get you to push up. Push, push, push. Fantastic. Much better. Come back for me. Push up a little bit. Push, push. Great. And relax. Okay. On your back for me, please. All right. So, how does hip osteoarthritis start, or what is it? Essentially, the hip joint is a ball and socket joint. Between the ball and the socket, you need to have a space. What has happened with Mr. Ashcroft is the space between the ball and socket has reduced, and this is what's giving him his hip pain. So, what we're going to do is some mobilization of the hip joint just to free up the joint space to allow some breathing room for the ball in the socket. Okay. Let's get you to bend your knee for me. There we go. Okay, you ready, sir?
Yep.
Yeah. Okay, so let's get going. So what I'm doing here is called a lateral distraction of the hip joint. You will see that as I pull this way, the joint is opening up. Any discomfort?
No.
Any pain? All right, so what is arthritis and what is osteoarthritis? Both those terms are used very interchangeably, but arthritis commonly refers to inflammation of the joint, whereas osteoarthritis is inflammation of the joint together with degenerative changes, so loss of joint space and sometimes some bony changes, formation of bone spurs or joint sclerosis, which is when the body lays down more bone where two bones are touching each other. And that's what we've seen in Mr. Ashcroft's x-ray. We just had a quick chat before we started with our examination, and essentially what we're trying to do is put off a hip replacement for as long as we can, right?
Yeah, if you say so, Doc.
You okay?
Yep, it's fine.
Okay. Let's get you to lift your leg up for me. All right. Is it fine? Is it
Yep, it's
about?
fine. That's good.
So what I'm doing is I start with external rotation, which is external rotation of the hip, internal rotation of the foot. I want to work the areas or work the movements which are least painful before I go into the movements which are most uncomfortable. So are you sailing today?
Not today, no.
today?
No, the boat's out of the water at the moment.
Yeah. When are you planning on getting onto the sea?
She'll be back on next Wednesday.
There we go. All right. Any pain?
No, it's fine.
Okay, so let's retest. See how this feels. Okay. Any pain there?
Just beginning.
All right. Let's look at the external rotation. So automatically you see there's quite a good improvement in that position, as well as this one. So we go again. Always like to do a round of each movement, assess, and then treat again, reassess. Just keep going through that cycle so I know what's working, what's not working. You're not having any knee pain, are you?
No, not now, no.
No. Okay. Okay. So one of the two common areas affected by hip pain is the lower back and the knee. When the hip starts to lose range of motion and mobility, it can trigger lower back pain as well as knee pain. So in Mr. Ashcroft's case, he's not experiencing either of the two, lower back or hip pain for the moment. So what we're trying to do is prevent that by improving the mobility, range of motion of the hip, and reducing his inflammation and pain. Feel the distraction in the hip?
Yeah.
Yeah. Any discomfort there?
No.
So you were mentioning that you were in the army. How long did you serve for?
About 11 years.
11 years.
Yeah.
And when you left, what rank did you have?
I was captain.
Oh, you were the boss.
Hardly the boss.
Hardly the boss. Boss of your what is it?
My little unit. Yes,
there we
little
go.
unit. Yeah. Yeah. But great days.
Okay, let's do this again. You still keep in touch with any members of your unit?
Oh yeah. Very good.
There is a veterans association or sports club here. They call DMC. Have you heard of them?
I don't know that one at all. No.
It's called Dead Man's Click. Yeah, it's all ex-Royal Marines and...
Oh, where from? All over the world, you know?
Most of them served in the Royal Marines.
Really?
Britain? Britain.
Really?
Yeah.
Okay.
But I guess they open to all veterans.
Yeah.
And I treat a few of them. And they have a nice,
They're all getting older like me, and they've all been beaten about by being in the military.
Some of them are still serving in various different capacities as advisors, you know, to, I guess, security companies and stuff.
Sure. All the military here.
Yeah.
UAE military.
They have a nice organization. They work from a place called the Vic Sports Complex.
Okay.
And they have a nice community.
I never heard of that. It's amazing.
Yeah. They do some training, martial arts, Brazilian Jiu-Jitsu, boxing, kickboxing, Brazilian Jiu-Jitsu, weightlifting, that type of stuff.
That's interesting.
There's a nice community around.
Yeah, terrific. They'll just send me some details.
Yeah.
I've never heard of it. I've got lots of military friends here. Never heard of it.
Maybe you can go over there and show them a few moves.
Why not? After your work, I'll be able to do anything. Yeah. So after this treatment, how long does it take before it the hip settles back into its old position?
So
it's great work.
That's a good question.
In cycling, I do my cycling now, my walking, so...
We will know after your medication stops and you progressively return to sport what the hip's going to feel like. It's never like an easy road with osteoarthritis or degenerative changes. We have to try and do as much as we can from a treatment and rehab perspective and then progressively load you. Obviously, you're working with someone who's doing exercise rehab in Alan, right? So he will progressively load you, and from what he sees, he will give you an indicator as to whether you can pick up the intensity. As you pick up the intensity, we'll just monitor you and see if the hip re-triggers with any pain or discomfort. Then we'll make small changes. We'll know what your tolerances are. Essentially, we want to build up your tolerance level so you can return to doing whatever you're doing at 100% without re-triggering any pain or discomfort in the hip. How we work with degenerative changes is similar to how we work with athletes in return to sport protocol. So if you follow any sport, let's just take football, for example. If an athlete gets injured, the first thing they're going to do is they're obviously going to assess him. They're going to start treatment. And then they start rehabbing him. Then from rehab, it goes to progressive return to sport. So if it's football, maybe he'll play a game with the reserve squad. 20 minutes, 30 minutes. Then he'll play a full game with the reserve squad. Then he'll come on in the last 15 minutes of a game that they're winning during the Premier League, you know? And then maybe the next week he'll come on and he'll start but come off. So we want to try and follow a similar type of protocol with you.
Sounds good.
Maybe not so long and drawn out.
I hope not.
Like you've had a serious injury, but something similar to that, maybe over a couple of weeks. It's been 3 weeks. All we've changed with you thus far is we've swapped the long duration walking for cycling, and we've continued to load you. So not bad.
This is progressive. This would have happened even if I didn't have that skiing injury 2 years ago, is it?
Yes.
It's
At some point in time, you would
it.
have needed something could have triggered it.
Yeah.
Something would have triggered it. So with Mr. Ashcroft, when we look at his X-ray, he's got hip osteoarthritis in both hips, but the right side is the one that has triggered. So the question is why? Why did it trigger? He had a fall in the summer that could have shut off the muscles supporting or stabilizing the hip, putting more strain on the hip joint, and creating more inflammation and injury of the cartilage, which ultimately resulted in his pain. But it's hard to tell, you know? It's like, what came first, the chicken or the egg? You may have been able to leave us here on this earth without ever experiencing hip pain, but we would never know, right?
Yeah.
So what we're doing with Mr. Ashcroft now is he has a follow-up MRI just so that we can check out the hip joint, see what's going on in there in terms of the cartilage, the labrum, just to do a full and thorough assessment. Once that's done, then we're getting booked in with the orthopedic to have a consultation and get an idea of what it's looking like in terms of hip replacement surgery. Something we're trying to avoid. If we can work around it through maybe an arthroscopy or intra-articular injection, we'll investigate that with the orthopedic. Let's have a look. See what's going on here. How's that?
That's good.
Any pain or discomfort?
No.
Nothing? Great. So we've been able to improve hip flexion. Let's have a look at external rotation. Not bad at all from where we started. Yeah. Not bad at all. Okay. So now that we've mobilized the hip, what I want to do is fire up the muscles that are stabilizing the hip. So when Mr. Ashcroft stands, the hip doesn't just go back into its position. The muscles that are surrounding it, that are providing it with stability, will be there to support it and maintain its integrity. So we're going to get into your favorite part of the session, the shock therapy. Maybe for our viewers, you can just for our seniors that may be watching, maybe you could just say a few words on how important it is for people to stay active as you get older. Because I know you're doing quite a bit, right? You're training with a personal trainer.
Yeah.
You sailing, you walking, you mountaineering. How important is it for you to just continually stay active physically?
Yeah, I've always been very keen on sport. So I played a lot of rugby, used to row, and in the army, of course, we kept really fit until I left at the age of 29, which was quite a long time ago. Since then, I've always tried to keep fit, and really in more recent years, say the last 15 years, I've been doing a lot of mountaineering, which I found really great because that would give me an objective. So I could go to the gym, train for that specific objective in mind, and that was a huge help. And then since then I've done other sort of less active sports, but things like surf skiing, which of course that actually has an effect on the hips as well as the shoulders. And then the sailing, which has been, of course, the leisure sailing is more about socializing, but the racing was really quite impressive and quite active. So always tried to keep fit. And then throughout that time, for the last 15 years, I've had a personal trainer. So when I'm in town, I have at least 2 sessions a week with that personal trainer, which has been really helpful and kept me quite strong. So generally, I'm now concerned because of my loss of mobility. So I'm now hobbling a bit, and I can't do some of the things I used to do. So I can't really go mountaineering. I've taken up a bit of cycling, which is obviously a very good way of not using your body weight on the leg, but still activating the muscles. So trying to find other ways of keeping fit and being able to do all the things I really wanted to do. So really, I would suggest to everybody, stay fit.
You can hold on to that for me. So All right, so we're going to go ahead and we're going to start some electro stimulation. We're going to start by working on the quad. Mr. Ashcroft is a pro at this. We also worked on his shoulder I think just before the summer. We found some great success there. So I think a common question is, how do you prevent hip osteoarthritis? The most important thing is to stay active. Stay active, do your mobility work, your stability work, your stretching, work on your glutes, work on your core, your psoas, foam roll, use a mobility ball. Listen to your body. Ultimately, like in Mr. Ashcroft's case, even unintentionally, these things can come up on you. But if you're looking after yourself, like how this gentleman is, it makes our life as therapists so much easier because we have a good platform to work with. Mr. Ashcroft has good athletic ability, so we can give him various exercises to use at home. I think the trainer that he works with, Alan's a good friend of mine. Alan pushes him quite hard. You get quite deep on those squats, eh?
Oh yeah.
Yeah. There we go. So, when you continue to maintain joint range of motion and mobility, not just in the joint affected, but in the lower back and in the knees, it makes managing an injury like this so much easier if it does creep up on you. So here we're working on the psoas. The psoas is a hip flexor. And what I want to ensure is that it continuously stays active. I have given Mr. Ashcroft some psoas activation exercises. Regardless, I want to continue to work on it every time he comes in here. Okay, so let's retest this muscle strength. You can straighten your leg for me. Lift up, please. Hold for me. Push up. Push, push. There we go. That is much better. Turn your foot out. Push diagonally across for me. Push. Fantastic. Okay, relax for me. All right, let's get you to sit, and then you're going to lie on your belly. I'm going to pop this off here for a second. Great. Let's get you to lie face down. Two major stabilizers of the hip are your glute med and min. So if you want to prevent your hip osteoarthritis from affecting you, or you want to prevent hip osteoarthritis in totality, if you want to ensure that your hip is stable and prevent yourself from getting any type of pain, lower back, sacroiliac, or your actual hip joint, you need to work on your glutes. So we also have given Mr. Ashcroft a series of glute exercises to do, and we're going to continue to work through our stimulation technique to ensure that they are firing. So we've got glute med here. We've got glute min. Can you hold on to that, please, for me, sir? All right, I'll grab that from you. Thank you. If you're watching this and you like what you see, don't forget to hit the like button. That was a bit of a tongue twister for me. Can you feel that, sir?
Not yet.
How's that?
It's fine.
If you guys have any questions on hip pain, hip osteoarthritis, hip arthritis, please drop them in the comment section below and I'll be more than happy to answer them. Okay. So this is Mr. Ashcroft's X-ray. This is what we call the femoroacetabular joint. This is the ball. And then this is the socket that I was talking to you about earlier. The space between the ball and the socket here, you can see it. You can see the space and then all of a sudden it disappears. This is what we call non-uniform loss of joint space and is an indicator that he is experiencing hip osteoarthritis. This is the right hip. If we look at the left hip, it's the same issue. Here you see the joint space and then all of a sudden you don't see it at all. This is a clear indication of hip osteoarthritis. Common injuries that I find in older population are osteoarthritis of the hip, osteoarthritis of the knee, degenerative disc disease or lower back osteoarthritis, cervical or neck osteoarthritis, shoulder osteoarthritis. Those are the common things that I see in the older population, but mostly lower back, neck, and hip. Those are the top three, I would say. Okay, let's get this out. Okay. Can you raise your left leg from your hip for me, please? From the hip. You can keep this straight for me and then up. Good. And down. Left leg.
Right leg.
Sorry, right leg. Yes. Great. And down. Apologies. So, I want to manipulate the sacroiliac joint on the right side, but when I bring Mr. Ashcroft's leg into flexion, it's creating some impingement in the hip. So I'm going to use a different technique. It's called a drop adjustment. And what I'm going to do is just tension the sacroiliac joint here. And then I'm just going to give a light push down and it's going to adjust the joint. Let's try that again.
Sorry, I thought I'd turn that phone off.
No stress.
It's in the...
If we look here, we see equal leg length. All right. Okay, sir. Let's get you to sit for me, please. Let's get you to walk around for me, please. Tell me how that feels.
It's the tight trousers that are the problem. No, that feels very good.
Great.
It's no sort of hobbling now. It's much easier.
Much easier to walk?
Much easier, yes.
There we go. All right. You can come take a seat for me. Well, okay, guys, that brings an end to our session today. That is what hip osteoarthritis is, how you test for hip osteoarthritis, and how you treat hip osteoarthritis. I've also discussed with you how we're managing Mr. Ashcroft and how we would manage a patient with hip osteoarthritis. Mr. Ashcroft, normally at this point, I allow our patients to give over their social media details. I don't know if you want the whole world having access.
You want the truth or?
Thanks to our viewers, you're more than welcome to on your experience.
No, I've had, this is a fourth session, and Dr. Ranen's been absolutely brilliant. I've been to other physios before, and I would, of course, he's a chiropractor, not a physio, but he is just a league above anybody else. His analysis of the problem is absolutely first rate, and we've been working together, and he'll send me WhatsApps, and I'll just tell him how I'm getting on. And then I'm working with my personal trainer as well. So the three of us are sort of making good progress. And I'm hoping I'm not going to have an operation, because if it's on one hip, it's going to be on the other too. So we're going to try and avoid that. But I want to get back to an active life again, or more active life. And this is my route to recovery, and it's first rate. Thank you.
Thank you for those kind words. All right, guys, please make sure to like, subscribe, hit the notification button. If you have any questions, drop them in the comment section. We'll see you soon.